Okay, so the first video stopped, was basically like the principles of analgesia. Now I want to go over the main agents that we have available to use for analgesia. Now, opioids should be reviewed because we did these when we did pre-anesthetic agents. Remember, the opioids were a category that we use, and the primary reason we use opioids in a protocol is to provide pain relief. Now, sometimes opioids do give some sedation, but that's not the main reason I use these drugs. They are for pain. Now, they are often used for surgery, pre-meds, during, post-op. We can send them home, but they can use for any animal that is painful. They vary in how potent they are and what are their adverse effects. Now, if you remember when I talked about using morphine as a pre-med, if you give morphine by itself, it's a good pain reliever, but it's typically combined with a tranquilizer because they enhance each other. Tranquilizer gives us sedation, morphine gives us analgesia. The opioids are very good at diminishing windup. So by starting as a pre-med, we don't get to that wind-up pain cycle. Most of the opioids in general last 2 to 4 hours. But again, remember, if you give it IV, you might get 2 hours. If you give it IM or sub-Q, you're going to get closer to 4 hours. That's why I've told you guys I prefer to give my pre-meds in the muscle. That's the preferred route because it may take a little longer to kick in, but it's going to give me a longer duration. Whenever you combined a tranquilizer and an opioid, you produce a state of sedation called neuroleptal analgesia. Neuroleptal analgesia just is a tranquilizer, which is neurolept, and analgesia, which is a pain med. Generally, it gives you enough sedation and analgesia for the pre-op, through the surgery, and maybe a little bit post-op. Because again, a spay in practice may only be a half hour. If these drugs last 2 to 4 hours, you, in theory, should have enough for the pre-med, during surgery, and post-op. But you're always going to have those patients that are more painful or react differently, and you may have to redose. And that's going to have to be, that's on a case-by-case basis. And it's just going to depend on the patient. So opioids in general, if you remember, they are generally very good analgesics, can be given alone, but are usually pre-op, they are usually given with another drug. Post-operatively, we will usually use morphine by itself. Like if I pre-med a dog for surgery with ACE and morphine, that's pre-op, but usually post-op, I only give the morphine because when they're waking up, I don't need the sedative part. I just need the analgesic part. They do have some sedative and anti-anxiety. Now, these are opioids in general. Everything I'm saying is all of the opioids. But let me give you an example. Butorphanol is technically a better sedative than morphine is. Morphine is a better analgesic than butorphanol. But sometimes we will choose butorphanol as our analgesic if we have an animal that we really need some extra sedation for. But remember, and I love to ask this question, what species are sensitive to opioids? Cats and horses. When it comes to anesthesia, to me, cats are small horses. They act very similarly, except one is 10 pounds and the other one's like 1,200 pounds. But the theory is they have more opioid receptors. So when I give a dose to a horse or a cat, they have more receptors. They're going to soak up more of those drugs. They're going to potentially see more of those side effects. So one thing that I want you to understand, if I use morphine in a cat, because usually if you're going to use opioids in horses, they say, or cats, you're better with the partial agonists or your agonist antagonist because they're not as potent. Very rarely do they want you to use a pure agonist in a horse or a cat. If I do, I either give them low doses on those and I give high, like sedative or tranquilizer doses to counteract any excitement. So if I ask you what two species are sensitive to opioids, cats and horses. All opioids have an interesting GI effects. When you give morphine, and this is seen more with the pure agonists, when you use morphine and hydromorphone, a lot of times you're going to increase GI activity. So sometimes they start to drool. Sometimes they have vomit and they end up defecating because it causes an initial GI stimulation. After that initial stimulation, post-operatively, if you keep using opioids, it can actually cause constipation. So then we like flip it. So we usually get an initial stimulation followed by a slowdown. Now, if you only use them for a day or two, the constipation's not going to be severe. It just may be mild. So potential complications if you slow down the GI tract could be ileus. Ileus is when the GI tract is not moving. Colic is GI pain. And if you slow down the GI movement, you tend to get gas buildup. And that's what causes colic. And then you can even get constipation. All of these drugs are metabolized in the liver. So you should have a patient that has decent liver function. If they have some liver impairment, we're just going to adjust the dose. So the ones that I want you to know are morphine, hydromorphone, and fentanyl. Oxymorphone, some clinics still carry it, but oxy is just like hydro. They're pretty similar. And then Demerol or methadone, we do not use in the United States. We may get that here, but for now, I just want you to know morphine, hydro. These are the opioids used for severe pain. If I was to ask you on a test, which opioids are good for severe pain? These are all your Schedule 2. So pure agonist, let's start with morphine. I'm just going to review. Morphine is a Schedule 2, which has the higher abuse potential. Moderate pain can be used as a pre-anesthetic. And if you remember, I gave you that chart that showed you the receptors and what it stimulates. The pure agonists stimulate all the opioid receptors, mu and kappa. So that gives you euphoria, pain relief, but you also get some respiratory depression. And again, you can get some dysphoria in horses and cats. This is good to know. I can give morphine, IV, IM, sub-Q. Intra-articular is in a joint. Remember, articular means joint. You can put it in a shoulder joint. You can put it in a stifle joint, and it's going to treat the pain in the joint. You can give it via epidural. We don't typically do spinals in animals. They do spinal injections in people. But we do epidurals. I have given patients, when I talked about epidurals, remember I told you, you can either give lidocaine in an epidural or you can do morphine by itself. Morphine, I also want you to, you can put a note, is very cheap. It comes with preservative and preservative free. If I use it in an epidural, I give the preservative free version because the preservative can cause a reaction and cause inflammation. So whenever we use it in an epidural, we always use a single use preservative free vial. Okay, so effects of morphine: GI stimulation. You can get colic in horses, which slows it down. It can cause excitement. It kind of breaks down the barriers and then they kind of can get crazy. Dogs tend to get meiosis, which is where the pupil constrict. Cats get saucer-eyed. They get mydriasis, and their eyes get very big. So their pupils react different, and it can cause some hypothermia, although that is typically later. But there is reports in cats that can become hyperthermic after administration of opioids. And it typically, when we use morphine, it typically is self-limiting. So what I'm talking about is the fever, it's not like it's lasting for weeks and weeks and weeks. Sometimes it's just that night, the next morning, that they get this hyperthermia, and then it typically goes away. And they're actually not sure why. I've tried to find research, and people are kind of not sure. Some other effects of morphine is you can get bradycardia. Sometimes it causes panting, but it also causes respiratory depression. Don't worry about ocular pressure or urinary retention. That's when we're talking about higher doses. I really want you to know the GI stimulation, the colic, and what it does to the eyes. Now, obviously, physical addiction. Opioids are addictive, but I don't have a dog trying to sneak out of the house at night and go get morphine. But if we use a lot of morphine in a dog, we don't wean them off. We literally stop the morphine, switch them to another drug. But what happens is when you do that, you can get some whining post-op, some crying post-op, and that's a little bit of, some of it can be interpreted as addiction, but it's not like how it is in people. Okay. I'm going to skip over oxy and go to hydro, another opioid ANCA Schedule 2. It's less potent than oxy, but it is cheaper than oxy. It's more expensive. Morphine's cheapest. Hydromorphone would probably be a little more cost. It's IMIV sub-Q, so we don't typically use this in the epidural space. It's typically as a pre-med. I will tell you, we use hydromorphone is probably the #1 drug we use at BCA. When we have a trauma come in, and I don't have time to talk to the owner and get a huge history, sometimes you have to treat an animal's pain. Hydro is a very safe drug to give when I know minimal information, because it may cause some bradycardia, respiratory depression, but it's not severe. It's completely reversible. So if I get into trouble, I can reverse it. And it's an effective drug. Now, I want you to put a note on here that they are sound sensitive with hydro. So when I do have a patient on, I say that anytime an animal is on sedatives, okay, anytime they're on opioids, I'm quiet around them. I even put cotton in their ears. But this one, they tend to be a little more sensitive to, okay? And then let me talk about the big gun, which is fentanyl. Fentanyl is a Schedule 2, and it's probably the most potent agent that we have currently. The nice thing about fentanyl is, now I want you to know, fentanyl should be given IV. Okay, I know it says IM and sub-Q here, but fentanyl only lasts about 30 minutes. So if you give it in the muscle, or if you give it sub-Q, you might be giving that dog a shot every half hour. Does anybody want to give a dog a shot every half hour? Not me. So generally fentanyl, when we use it in the hospital, we do it via a CRI. We give it continuously as a drip. So a lot of patients will be so a lot of dogs, let me give you a scenario. They're pre-medded with morphine, induced with propofol. You go into the OR, you go into surgery, and then you hook them up to fentanyl, and they will get a fentanyl drip. And what that does is it gives a little bit of fentanyl continuously. It can really lower your inhalant. If I have an animal that I'm worried about blood pressure and it's a very critical surgery, a lot of animals will be maintained on fentanyl with a very tiny amount of ISO. But because fentanyl is taking care of the pain, we don't need a lot of inhalant. Now, I'm going to talk about this coming up, but fentanyl is in a patch. So you can get, we use patches, they use them in people, we have them in animals, and that will give an animal fentanyl low dose in their system over like a 72-hour period. Okay. You can also use fentanyl with midazolam or diazepam to induce anesthesia. So we got so fentanyl is a very popular drug. If you look on the little gray box underneath, here are some other notes about fentanyl. Let me mention something, I'm going to bring it up again. Fentanyl is a very potent respiratory depressant. A lot of human drugs, and this is where I get into my mom talk, a lot of human drugs on the street, illicit drugs, are laced with fentanyl. But sometimes people buy drugs on the street, they do not know fentanyl is in the drug. They think they might be buying marijuana, coke, whatever drug someone's trying to sell you, OxyContin, and then people add fentanyl to it. Well, the problem is fentanyl is such a potent respiratory depressant. When people die of a drug overdose, if there's fentanyl in it, the most common reason these people die is they stop breathing. Because if I take OxyContin and mix it with fentanyl, those are two very respiratory depressant drugs. And it can actually stop someone from breathing. So when I use fentanyl in patients, I'm very cautious of their respiratory rate and how deep they're breathing, because it can be severely affected to the point that we would have to reverse them. I mean, if it gets severe, like, remember, whenever you reverse a patient because of something bad, you take away the good. So there has to be certain situations. Now, remember when I talked about reversal, you use Narcan, is a pure antagonist, takes away fentanyl, which is a pure agonist. Sometimes I can give butorphanol, a little bit of butorphanol, because it has only a little bit of an antagonist, and it is good to reverse the respiratory depression, but it doesn't necessarily take away the sedation or the pain. Okay. Those were all pure agonists. Now we're going to talk about butorphanol. It is an agonist/antagonist. So it stimulates kappa, but it actually blocks mu. Now, there is some things to adjust on the slide. It is actually a Schedule 4. It is not a Schedule 3 because it doesn't have a high abuse potential. I mean, nobody's breaking into your clinic to take butorphanol. And if they are, more power to them. It's not going to do anything. It's not a very potent, doesn't have a high abuse potential, but it is not as effective analgesic. If I have a patient that has a fracture, that was a hit by car, was a trauma, you need to be using pure agonists, morphine, hydrofentanyl. Butorphanol would be mild to moderate pain, but butorphanol is good for cats and it's good for horses. Because it's not a full agonist, you're not going to see that opioid excitement like you do with morphine. So I know butorphanol is used a lot in horses, and it is used, it's good for cats. The problem is butorphanol is fairly expensive. It hasn't come out kind of like with a good cousin, so to speak. That's a weird way to say it. But the cost of butorphanol is an issue, but we have it at school. I will say at school, we do not carry any Schedule 2 drugs. So you guys will not use morphine, fentanyl, or hydro at school. we don't carry them because of the record keeping and the fact that it's just, you don't want to mess with it. So we do have butorphanol. It's not as effective, but it produces less sedation, less dysphoria is when they go crazy. Euphoria is when you're like, I feel great. When you're dysphoric, it's like, it's a dysfunction of your euphoria, paddling, vocalizing. So you get less of that with butorphanol. We also get less respiratory depression. When I've told you guys the story when I overdosed that cat by accident, I was using butorphanol. And when I said I picked the right drug to overdose, I mean, it was an accident, but luckily it was a drug that didn't cause respiratory depression. The cat, no change in respiratory rate, no change in respiratory effort, okay? And the nice thing is you can use it as a partial reversal. You will not get full reversal with butorphanol because it is a partial agonist. But you take a ml of butorphanol, you put it in 10 mils of saline, and what you do is you start to titrate it, which means you give a little, a little, a little. When the respiratory rate starts to come up, I stop giving it. So it's used to do this kind of like get a little boost in your respiratory system. And again, it should be a Schedule 4. Here are some notes. Actually, this says buprenorphine, and that should say butorphanol. So that's a mistake. Butorphanol is a great pre-anesthetic. It does, and I will say, butorphanol has some decent sedative properties. Remember, if I have a shelf and I have all of these drugs and I'm like, which one am I going to pick? Sometimes I lean to butorphanol if I want a little boost in sedation. You can give it IMIV sub-Q. It does come in tablets. And if you want to put a little side note, here's some notes about butorphanol under here. Butorphanol actually has some cough suppressant properties. So sometimes we've had a really bad kennel cough case. Like sometimes kennel cough, we just cannot clear it up. And the poor dog is hacking. Sometimes we'll send them home with butorphanol tablets. 2 reasons for the cough, but have you ever had a bad cough and you just hurt, your ribs hurt? So the nice thing about butorphanol is it can help with chest pain for coughing, and it also helps suppress the cough. But it's very expensive. Butorphanol tablets are not cheap. So not every clinic carries the tablets, and not every owner, you know, if you got like a big Mastiff, that's going to cost you a pretty penny in butorphanol tablets, because I believe they only come in one strength, and I can't remember. We wanted to send it home with this German Shepherd, and I think the dog was going to have to get like 4 tablets, like 2 or 3 times a day. And by the time I put it in the computer, I think it was going to be like around $200-300. It was really, really expensive. The owner's like, nah, I'll just go get some syrup at the store. And we're like, okay. So again, Schedule 4, I don't know why that previous slide said a Schedule 3. Now, buprenorphine. Okay, so the only agonist-antagonist you need to know is butorphanol. Buprenorphine is known as what's called a partial mu agonist. It has no antagonistic properties, but it only partially agonizes the mu receptor. Now, mu is associated with that euphoria and pain relief. So it's good. Another, buprenorphine is similar to butorphanol because it's good for mild to moderate pain, not severe pain. But if I ask you on a test, you know what that means. What is the cat analgesic of choice? Buprenorphine is good for cats. So buprenorphine acts well in cats, but you can use it in dogs. It's a little expensive in dogs. And so I would say doctors usually favor butorphanol for dogs and buprenorphine for cats. But I know at the school, we use buprenorphine in dogs as well. It says you can reverse the effects of morphine and fentanyl. This is unpredictable. I don't agree with that. Okay. You can give it IMAV, sub-Q, but I want to highlight orally to cats. The true benefit, there's two things I want you to put on this slide in your notes. One is that right here, delayed onset of action, longer duration. Remember I said most opioids last 2 to 4 hours? Buprenorphine can last 8 to almost 12 hours. So for example, if we have a declaw, I know a lot of people don't do declaws anymore, but we will give cats buprenorphine, we'll draw it up in a syringe, and I'll fill like 4 syringes, 6 syringes, and then I take off the needles and we send it home with the owner. And what the owner can do is they give it sublingual and they give it buccally. You do not give it orally. You have to understand this. You do not squirt this in the back of their throat. You do not put this on their food. It is not meant to be ingested. It's meant to be absorbed through the mucous membranes. There is a study that tested sub-Q injections in cats of bupe, sublingual administration of bupe, and those cats achieved equal plasma levels, which means it was absorbed sublingually just as good as it was absorbed sub-Q. So the advantage is I'd much rather give a cat something under its tongue than put a needle in it. And I'm sure an owner would rather give its cat something under the tongue rather than have to give it a shot. So the nice thing about buprenorphine, I don't really have to worry about people abusing it, or you always have idiots out there who would try, but not fun. But I want you to know, of the opioids that last the longest, fentanyl lasts the shortest. Buprenorphine gives you the longest duration. That's the other reason I like it in cats, because do I want to give a cat something 4 times a day if I can give it something twice a day? If I can go 12 hours, you can give buprenorphine up to 3 times every 8 hours, but in some cats, you'll get that 12-hour duration. What I used to tell owners, I said, you give it under the tongue. If you feel like your cat is painful in 8 hours, go ahead and give it. But if not, wait 12 hours. But everybody assumes if something goes in the mouth, they can just squirt it on food. Well, the problem is that's not how this works. And you would also have to make sure, I'm not a fan of putting medication in food because you have to make sure they eat it all. So it's an inconsistent way to administer medication. It says below here, Schedule 5 drug. It is technically a Schedule 3. So I'm sorry that there are errors in these schedules, but it is a Schedule 3. Now, how we give all these opioids that I just talked about. You can give them, post-op. So you have some options, okay? You can either give them IM or sub-Q before they are actually conscious. That's a decision based on the doctor, okay? If your patient is very asleep, if they seem like they're not feeling pain, like they had a good heart rate, they weren't a tough surgery, then usually we'll just give it maybe sub-Q or we'll wait till they're awake. We can also give post-op pain epidurally, articularly with a patch. The problem is if you give it IM or sub-Q, you can see some of these potential disadvantages. Although, if I didn't stress this enough, if they get kind of vomiting and defecation when you give it as a pre-med, they tend to not do it post-operatively. So you don't see as many of the gastrointestinal effects as you would. But let me explain how this works. Okay. If I gave a dog a pre-med of morphine at 8 a.m., this is how we did it at Purdue. If we gave it IM at 8 a.m., it got us about 4 hours of analgesia. If the surgery was done at 11, that dog technically isn't due for an hour because it's not 4 hours. So I would look, how's my heart rate? How's my patient? Sometimes the doctor goes, go ahead and give it. So sometimes we gave it early, but that patient would normally get morphine every 4 hours for 24 hours. So if I gave it at 8 a.m., he'd get it at noon, 4 p.m., 8 p.m., midnight, 4 a.m., and then at 8 a.m., we would either take him off the morphine, or we would start oral medication, or we would continue injections. It just depends. So that's one way that you give it. But what you have to do is you time it from the first dose and how long. Now, if it's buprenorphine, if it's 8 a.m., the next dose wouldn't be due maybe 6 to 8 hours, would be 2 to 4 p.m. You can also do what's called an intravenous infusion. So you can give morphine, fentanyl. I've never used butorphanol as like an infusion, like a drip. Most of the time, if we're going to do an infusion, which is normally a CRI, constant rate infusion, we're usually going to use morphine or fentanyl. Those are our two most common agents. Okay, so how do we do a CRI? And I believe you talked about these when you talked about fluid therapy in Tech 4. And a lot of times at the clinic, you'll get training if you're going to do a lot of CRIs. But what you have to do is make sure that the animal has had a loading dose. That could be your pre-med. That could be, but what you're doing is you're giving something, because a CRI is a low dose drip. Usually we got to get their plasma levels with a loading dose. That's why we give a loading dose. And then what we typically do, sometimes we put just fentanyl in a big syringe and attach it to the line. A lot of times we put fentanyl in the bag of IV fluids, and then we hook up the IV fluid. So the fentanyl mixes. But if anybody's been in a hospital, you've been in a hospital yourself, and you get the little button and you push because you got morphine hooked up to you, it's a similar process. But what you have to do is when you're dripping this in, you can't just ignore it. Okay? So we're going to have to watch their respiratory rate, watch their pain level. Sometimes you can turn the pump up or down and give more or give less. But there's always an assessment of the patient. Is the patient responding? Morphine can be used. You can do a morphine by itself, CRI, but there's a drip we use a lot at VCA, and it's called MLK, morphine, lidocaine, and ketamine. Lidocaine is added as a systemic analgesic. And remember, I said we don't usually use lidocaine IV. We're only talking about a little bit. Okay, so we're not talking about high doses. And then we use ketamine. Ketamine is typically an induction agent. Ketamine in this is very low. This is not ketamine to make your animal fall asleep. It's not enough ketamine to make your animal very rigid. It's a very low dose because ketamine has analgesic properties. So we're only giving enough ketamine to just give some analgesia. So I want you to know what MLK stands for: morphine, lidocaine, ketamine. Now you can give morphine intra-articular. Morphine is the one commonly used. We typically mix it with some saline, and it can add analgesia in the pain receptors in the joint. So it's another way. That's kind of rare. What's more common is to use it via epidural. L7S1. Remember, you can use bupivacaine, which is what I talked about in the previous lecture. You could use morphine, or you could give morphine bupivacaine. It's doctor preference. Some doctors, want to give both. Remember, an epidural is for hind limb, caudal, abdomen. Very rarely do I see it used for the caudal thorax. If you had a diaphragmatic repair, you could use it, but you have to use caution when you push those drugs up close to the thoracic spine, that we don't get any paralysis of the respiratory muscles. Now, morphine would not give you that paralysis, but you have to be used with caution. Alpha 2s can be used in large animals, but one thing I want you to know, if you're doing an epidural, morphine has to be the preservative free, because they can react to the preservative in that drug. And then I've already talked about the procedure of an epidural. If you add morphine, like an opioid, you can either do, epidurals are usually done before surgery. You can also do them after surgery. It takes somewhere in up to an hour to take effect. This is what's strange, is sometimes epidurals are going to last 6 to 24 hours. But remember, if it's morphine in the epidural, you're just going to get pain relief. You shouldn't lose function. The previous lecture, bupivacaine can cause them to not be able to use their legs for 6 to 24 hours, which you would just have to provide nursing care till those drugs wore off. Again, an epidural is never used by themselves, and you always have to make sure the animal can turn themselves. They cannot be on their sides longer than 4 hours. And so if they're right lateral at 8 p.m., midnight, you may have to turn them over, 4 a.m., 8 a.m., keep flipping them back and forth. Now, what about opioids that we can send home? One common way in people, and I guess I wouldn't say super common in veterinary medicine, but if it's an advanced practice, they would use transdermal fentanyl. So it's a little fentanyl, and I believe there's pictures in the book. I don't want to mess up the video, so I'm not going to try to go on the internet. But it's a little plastic patch, and that inside there's gel, and that gel is fentanyl. What you have to do is, we will usually shave a patch of fur, because that has to touch the skin. That's why some people, they stick to people's skin much better. But what I used to do is sometimes between the shoulder blades or the lateral thorax, you want it to be somewhere where the animal can't turn around and ingest it. So some doctors have a preference of where they're put, but I would clip the fur. I would usually take an alcohol swipe to wipe off like the sebum and the excess fur, and then I would dry it, okay? Don't put a patch on right after you wipe it with alcohol, because it'll fall off. So I usually swipe it with alcohol. It doesn't have to have a surgical scrub. The alcohol helps remove the oily substance in the skin. It also helps remove some of the fur, and they stick better, but it has to be dry. You're always going to wear gloves when you put them on. The fentanyl side touches the patient. But normally, and I don't know if you guys know this, it's a little tip. Whenever you use Zonus tape, a Band-Aid, a fentanyl patch, if you put your hand over the plastic, body heat activates the adhesive. So when I put in a catheter, sometimes I hold it with my hand for a couple minutes, because my body heat's going to help the adhesive stick to the leg. I do the same thing with a fentanyl patch. I put my hand and I let it sit, and that warmth will help it stick. There are, and these come in microgram, you would have to calculate the dose for your patient, 50, 25, 50, 75, 100. Now, we wanted to use it on a cat once, but we don't have anything smaller than 25. My boss wanted the cat to have 12.5. She took the patch and folded it in half, where only half of the patch touched the patient. So I have had people do that. Some people say you shouldn't do that, but that's the doctor's call. If you cut it in half, the stuff would leak out. So we folded it, stuck, and then we put a bandage to keep it folded. And you could put 2 patches on a patient. If you had like a Mastiff and they needed, 150 micrograms, you could use 100 and a 50. So you can put 2 patches on to get the dose you want. The advantage to a patch, it's a long-term administration. It acts like Oxy, but it's different. Let me give you an idea. When you put it on, it takes about 4 to 12 hours to kick in a cat, 12 to 24 hours to kick into a dog because it has to be absorbed. Cats generally have thinner skin than dogs. That's why it kicks in faster in a cat than a dog. Like if you've ever worked with a Shar-Pei or seen a Shar-Pei, they have very, very thick skin along with wrinkles. And so that one's going to probably be the 24 hours. Shih Tzu and Poodles have this really thin skin. It's probably going to kick in sooner in these guys. Now, if you want it pre-op, if you want to pre-treat, you need to put this on at least 12 hours before surgery. Most of the time, this is used post-op. So normally what we'll do, we'll give post-op morphine. We will put a patch on, and then we will discontinue the morphine 12 hours later. Because remember, this patch does not kick in, like in a dog, 12 to 24 hours. So we don't put this on for acute pain, and we definitely need to be giving them something for pain till this kicks in. That's very important. So it's good for trauma. We used a lot of fentanyl in cancer. The Aussie that had the big tumor on the jaw, that dog was getting fentanyl patches for 2 months. So it's good for a lot of things. The problem is the amount that is absorbed varies from dog to cat. So it's a little unpredictable. I always tell the owner, please let me know how they're doing because we may have to use something else. But most of the time they were pretty effective. You have to look for something called breakthrough pain. Now, if we are achieving pain management, breakthrough pain is there occasionally get these painful episodes. Sometimes we have to supplement with more pain medication. Hopefully, fentanyl patch is enough to keep us covered. This is where I talk about client education. There's some client education under here because, first of all, how do we know that we're not going to overdose the patient? One thing is an overdose of fentanyl is going to cause sedation and ataxia. It should not do that. A fentanyl patch should not affect a dog's ability to walk, interact, or eat. So if an owner says they're trying to walk and they stumble, they're hanging their head, they don't want to eat, we may have to we may tell them to take the patch off and we'll do something different. It's not on here, but I always teach my patients with patches how to take a respiratory rate because respiratory depression is a major side effect of fentanyl. So I talk about how often they should be breathing, how deep they should be breathing, and I always tell them if they see a change in effort, color, or rate, they need to call us because that's a sign of an overdose as well. We do use them in cats, not as often, and you have to be very cautious that they don't become dysphoric or disorientated. If we see any of those things I just talked about, we take the patch off. Now, some is always going to be in the skin, but if we take it off, that's our best bet. Also, I'm very cautious because if this is used and then we have owners that have children, they think it's, oh, a cute sticker. Let me take that sticker off Fluffy and I'm going to put a sticker on me. It can kill a kid. And I'm not joking. So I'm always very serious. I'm like, do you have children at home? Children cannot touch the patch. Children, and I say, normally the procedure is the owner comes back to the clinic and we remove it. Normally we flush them down the toilet. If an owner is going to remove it at home, I tell them to flush it down the toilet, because if it's put in the trash, an animal can ingest it and get an overdose of fentanyl. A child can play with it, can get an overdose of fentanyl. So this really needs to be flushed or disposed of at the clinic. Another huge thing to be aware of is if you have an animal with fentanyl patch and then they are laying on heat, heat increases the rate of absorption. Why? Because heat vasodilates the skin under the patch. And what that's going to do is it's going to increase uptake of drug. So if they have a fever, I don't use it. If they have any hot water bottles, if they're laying on a heating pad, they cannot lay on a fentanyl patch. I don't use heating pads. I don't use bear huggers. At home, I tell them, don't let your dog lay on the heat registers. Don't let your dog lay in a sunny window. And I mean, I'm grasping to think of where are heat sources that an animal can have access to. Because in rare cases, it can kill a patient if they uptake a lot of fentanyl quickly and then they stop breathing. So, caution, wear gloves, come back to hospital for removal. And there was a report of an owner that tried to take the patch off an animal and shoot up the fentanyl and died. So you're always going to have those idiots that are going to try and do stupid stuff. So I hope I'm dealing with an owner that I trust, an owner that's not going to abuse this. Okay, because people get addicted to drugs and they think, oh, I can take my pet's drugs. So anyway, I just be familiar. Tell me what I like to do on tests is talk to me on a test as if you were talking to an owner in front of you. So I just told you, what are some things an owner needs to know when we use a fentanyl patch? Boom. This is what you need to know. Okay, I'm going to stop this video here, and then I'm going to do a little bit later, I'm going to send out the non-steroidal, but I need to take a break and do some stuff, so I will send the next one out in a bit.